Sorry? No, no. Okay. This patient's clubbing, enlargement of the distal phalanges, flattening of the nail fold, and with painful arthropathy. Bilateral swelling and tenderness of the wrist joint raises concern for hypertrophic osteoarthropathy. Hypertrophic osteoarthropathy is characterized by painful bone and soft tissue enlargement, painful bone and soft tissue enlargement in the distal extremities. In addition to clubbing, common findings include tender, tender periosteosis, thickening of the periosteum of the long bones, and joint effusion. The exact mechanism of hypertrophic osteoarthropathy is unclear, but may reflect activation of the hypoxic inflammatory pathways with subsequent release of the platelet and growth factors. This likely explains why hypertrophic osteoarthropathy commonly occurs in the setting of pulmonary malignancy. Pulmonary malignancy including especially adenocarcinoma, which is the common primary lung cancer, which is the most common primary lung cancer in non-smoker like as this patient. Hypertrophic osteoarthropathy can occur with small lung cell carcinoma, lung metastasis, and certain non-malignant lung disorders, cystic fibrosis, bronchiectasis, and cyanotic heart disease. Initial evaluation should include chest X-ray with subsequent imaging, echocardiography to assess for heart disease, considered based on result and other clinical findings. Heart murmur. Okay. Looks like infection, isn't it? She has fever. She has sorry, he has fever, and there is dullness to perception. Looks like pneumonia, but it has not helped. Maybe the organism is different. Maybe. And there is chest X-ray show large loculated pleural effusion. Is it empyema? Okay, we should do drainage also. He is taking only antibiotic, like that's why it is not treating. Maybe. How? What should be its pH? Okay, it is complicated. Okay, okay. Effusion. Parapneumonic effusion. So he has bacterial pneumonia, often causes pleural effusion. So that's pleural effusion due to bacterial pneumonia. Bacterial pneumonia causing parapneumonic effusion. Okay, bacterial pneumonia often causes pleural effusion. Typically, the effusion is small, sterile, free-flowing, and resolves with antibiotic. However, if bacteria persistently invade the pleural space, a complicated parapneumonic effusion or empyema may develop. Patient with this pleural space infection, patient with this pleural space infection tend to have continued symptom, fever, pleuritic pain despite adequate antibiotic. Chest X-ray often shows loculation walled off pleural fluid. Thoracosynthesis show an exudative effusion. Thoracosynthesis show an exudative effusion characterized by. Can I call you 5 minutes later? My sister is calling. It will take 2 minutes. Okay. I'm reading the explanation again. Okay, starting from the box. Okay, for uncomplicated, uncomplicated sterile exudate in pleural space. Uncomplicated is sterile exudate in the pleural space. Small to moderate and free flowing. Small to moderate and free flowing pleural fluid characteristics. pH more than 7.2, glucose more than 60, WBC less than 50,000, WBC less than 50,000, LDH less than 1,000 unit per liter. Pleural fluid gram stain and culture is negative. In case of uncomplicated, it is negative, and treatment and is antibiotic. In for complicated, bacterial invasion of the pleural space, moderate to large, free flowing or loculated. Pleural fluid characteristics, pH is less than 7.2, glucose is less than 60, and WBC is more than 50,000, LDH is more than 1,000 unit per liter. Pleural fluid gram stain and culture. In case of complicated, it is positive or negative, and treatment antibiotic and drainage. Okay, bacterial pneumonia often causes pleural effusion. Bacterial pneumonia often causes pleural effusion. Typically, the effusion is small, sterile, free flowing, and resolves with antibiotic. However, if bacteria persistently invade the pleural space, a complicated pneumonic effusion or empyema may develop. Patients with these pleural space infections tend to have continued symptom, fever and pleuritic pain despite adequate antibiotics. Chest X-ray often shows loculation walled of pleural fluid. Thoracosynthesis will show an exudative effusion characterized by low glucose, less than 60 mg per deciliter due to consumption, high metabolic activity by activated neutrophil and bacteria, low pH less than 7.2 due to anaerobic utilization of the glucose by neutrophil and bacteria, and high protein due to increased microvascular permeability and cellular destruction. Empyema are differentiated from parapneumonic effusion and the presence of gross pus or bacteria. Presence of gross pus or bacteria on gram stain. Most complicated parapneumonic effusion and all empyema require drainage chest tube in addition to antibiotics. Okay. Fluid level. Is it a lung abscess? Mm, Is it small cell lung cancer? Is it fungal ball? Aspergilloma? Okay. Oh, okay. Aspergillus is a ubiquitous fungus that most people encounter daily. Conidia are inhaled into the lung and convert to potentially pathogenic hyphae. Patients with immunocompetency rapidly clear the organism and rarely develop infection. However, a subset of immunocompetent patients with a history of pulmonary disease, capillary tuberculosis may develop chronic pulmonary aspergillosis at site for lung damage. Diagnosis is made by the presence of all three of the followings: three or more than 3 months of symptoms: fever, weight loss, fatigue, cough, hemoptysis, dyspnea, cavitary lesion containing debris, fluid, and aspergilloma fungal ball, and positive aspergillus IgG serology. Therapy depends on symptoms, severity of the disease, antifungal medication, itraconazole, voriconazole, and surgery to prevent hemoptysis, bronchial artery immobilization. For hemoptysis with extensive disease may be used together separately. A simple aspergilloma is sometimes categorized as CPA, chronic pulmonary aspergillosis, but is typically quiescent aside from occasional mild cough hemoptysis with no systemic symptoms. This patient with chronic pulmonary aspergillosis rather than simple aspergilloma. Okay, box. Invasive aspergillosis, invasive for immunocompromised patient, and chronic like lung disease, lung damage, cavitary TB. And invasive, there is a triad: fever, chest pain, hemoptysis, pulmonary nodules with halo sign, positive culture, positive cell wall biomarkers like galactomannan and beta D glucan. And for invasive aspergillosis, voriconazole with or without caspofungin. And chronic pulmonary aspergillosis, uh, more than 3 months of the weight loss, cough, hemoptysis, fatigue, cavity lesion with or without fungus ball, and positive aspergillus IgG serology. Management is recent aspergilloma if possible, azole medication, voriconazole, and embolization if severe hemoptysis. Aspergillus is a ubiquitous fungus that most people encounter daily. Conidia are sorry. My head is not working. Next. Is it GRD? Like she is on famotidine. I think that it is due to that cough is due to. Oh, why I choose this? Fine inspiratory crackle hard on the lower zone. Velcro ILD.
Oh, I didn't
Okay, this patient with ischemic heart disease. This patient with ischemic heart disease has dry cough, exertional dyspnea, and inspiratory crackles. Given the lack of evidence of heart failure, like normal JVD, no peripheral edema, he should be evaluated for interstitial lung disease. Inspiratory fine dry crackle are sensitive for interstitial fibrosis, which is present in many patients with ILD. They are typically audible. They are typically audible long before abnormalities on chest X-ray or pulmonary function emerge, underscoring the value of careful auscultation. Early into disease progression, ILD may not be seen on X-ray. Therefore, suspected ILD should undergo HRCT. A thin slice, usually 1 centimeter, CT scan protocol developed to visualize subtle interstitial lung disease reticulation honeycombing. Compared to conventional CT, HRCT provides sharper image because slices are often seen in step and shout format. A prawn sequence is often awkward. A prawn sequence is often awkward to remove compressive atelectasis, allowing better visualization of subtle reticulation or honeycombing. In the dorsal dependent lung, the crisp detail offered by the HRCT allows specification of classification of the ILD, usual interstitial pneumonia, cryptogenic organizing pneumonia. In addition, HRCT workup suspected ILD involves full pulmonary function test, lung volume, and diffuse capacity. Okay. Patients with known coronary atherosclerotic disease are at risk of cardiac ischemia and congestive heart failure. Stress imaging is often complementary to pulmonary workup. However, although ischemia can cause dyspnea, angina equivalent, it does not explain dry cough and fine crackles. Although ischemic left-sided congestive heart failure can cause dyspnea, it usually associated with wet versus dry cackle for this program. Orthopnea, in addition, an inferior valve myocardial infarction is most likely to cause right-sided rather than the left-sided symptom. Okay,
Mm-mm. Dance. Oh,
Okay, it's anaphylaxis. Took time. Okay, this patient has acute onset respiratory distress, hemodynamic instability, and hemodynamic instability, urticarial rash. Likely has anaphylaxis. The most common diagnostic criteria. The most common diagnostic criteria for anaphylaxis include an acute illness involving skin or mucosa and either respiratory or cardiovascular compromise, hypotension or signs of end organ hypoperfusion. Other common manifestations include GI, neurologic, and ocular symptoms. If the diagnosis is unclear, serum tryptase or plasma histamine may be helpful. The development of patient's symptom after breakfast suggests a food allergy, which can which can develop at any age. Risk factor for anaphylaxis include immune disorders such as asthma and mast cell stabilizer. Patient with underlying pulmonary or cardiovascular comorbidity are an increased risk of poor outcome. Medications such as NSAID, anti-inflammatory anti-inflammatory drugs or beta blockers can exacerbate anaphylaxis by resulting in non-immunologic mast cell activation or unopposed alpha adrenergic effect, respectively. Treatment involves supportive care, including airway management, medications such as intramuscular epinephrine, and the preferred treatment. Okay.
since the anyone has severe respiratory disease,
Okay. Okay, look at the box first. In asthma, in asthma, total lung capacity is normal or increased. FEV1 by FVC is decreased, and DLCO is normal or increased. In COPD, in COPD, TLC is high. Total lung capacity is high, and FEV1 by FBC, as it is obstructive lung disease, so FEV1 by FBC is low and DLCO is low too. In ILD, it is a restrictive lung disease. In restrictive lung disease, TLC is low and FEV1 by FBC is normal or either increased, and DLC is low. In pulmonary arterial hypertension, DLCO is only low. Total TLC and FEV1 by FVC ratio is normal. Pulmonary arterial hypertension. In mm, restrictive chest wall disease, TLC is only low, but the FEV1 by FVC and DLCO is normal. Okay, so this patient, we this patient with progressive dyspnea, dry cough. This patient with progressive dyspnea, dry cough, and fine crackles in the absence of smoking, likely has interstitial lung disease due to IPF. On pulmonary function testing, IPF is associated with restrictive profile, typically decreased lung capacity, and normal FEV1 by FBC ratio, and reduced reduced diffusion capacity for carbon monoxide. Diffusion capacity for carbon monoxide, like DLCO, likely due to decreased pulmonary capillary erythrocyte volume and alveolar capillary surface. IPF commonly presents at age 50 to 70. Most patients have a history of smoking. In addition to fine bivascular crackle, patients in advanced disease may develop and respiratory squeaks, digital clubbing, and abnormal S2, loud P2, fixed and split S2 due to pulmonary hypertension. Evaluation should include a thorough history to identify the evidence of autoimmune disease, use of associated medication, amiodarone, occasional exposure, and therapeutic radiation. For example, this patient's long career in a Navy places him at increased risk due to asbestos exposure. Chest X-ray typically demonstrate non-specific reticular infiltrate, but chest CT findings suggestive of peripheral hilar reticular infiltrate, such as honeycombing, are more helpful in establishing the diagnosis. If imaging is non-diagnostic or the clinical picture is atypical, a biopsy can confirm the diagnosis.
uworld is
Okay, this is congenital diaphragmatic hernia. Pathogenesis is incomplete fusion of the pleuroperitoneal fluid, herniation of the bowel in the chest, pulmonary hyperplasia and hypertension, clinical feature respiratory distress, absent breath sound ipsilateral to the defect, absent breath sound ipsilateral to the defect, and concave abdomen, barrel-shaped chest. Chest X-ray, intrathoracic bowel lobe, displaced cardiac shadow, management endotracheal intubation, gastric decompression, nasogastric tube, and surgical correction. These newborns chest X-ray showing intrathoracic bowel loop, and a displaced cardiac shadow is consisting with CDH, congenital diaphragmatic hernia. Pathophysiology of CDH involve incomplete fusion of the pleuroperitoneal fluid during fetal development that results in a defect in the diaphragm, protrusion of abdominal content through the defect, most commonly left-sided into the thoracic cavity, compromises lung development leading to pulmonary hyperplasia and the following: respiratory insufficiency or failure within hours of birth. Patient typically develop respiratory distress, tachypnea, cyanosis, retraction with absent breath sound on the side of the hernia. The severity of the respiratory insufficiency typically correlate with the amount of the parenchymal tissue loss, with more severe cases leading to death in the first weeks of life. And pulmonary hypertension in utero, remodeling of pulmonary vasculature, reduced bronchial and pulmonary arterial branching leads to arterial muscular hyperplasia and persistent elevation of pulmonary vascular resistance. This contributes to respiratory failure with cyanosis due to right to left shunting, and over time right ventricular dysfunction and failure. Therefore, the leading cause of mortality in patients with CDH is pulmonary hypertension. Okay. She has lung crackles. Is it ARDS? And pneumonia is one of the risk factor of ARDS. She has fever, cough, hypotension, tachycardia. Okay, ARDS. This patient sepsis, fever, chills, hypotension from postpartum endometritis. Postpartum endometritis has rapidly progressive dyspnea, diffuse crackles, rapidly progressive dyspnea, diffuse crackle, bilateral lung infiltrate and acute hypoxemic respiratory failure. FiO2 is 100% and PaO2 is 60 millimeter mercury, resulting in PaO2 by FiO2 is 60 by 1 is 60. This presentation is most consistent with acute respiratory distress syndrome due to sepsis. ARDS ARDS in the setting of direct pneumonia aspiration or indirect sepsis, pancreatitis, lung injury. Sepsis is a dysregulated host inflammatory response to infection endometritis, which promotes increased alveolar capillary permeability, exudation of proteinaceous fluid into the air space, and recruitment of leukocytes and cytokines in the lung. Gas exchange is impaired due to severe ventilation perfusion mismatch owing to intrapulmonary shunt effect, perfusion of flooded and gasless alveoli. Lung compliance is reduced due to pulmonary edema and loss of surfactant. Bilateral infiltrate non-cardiogenic diffuse pulmonary edema are seen on chest imaging. Mechanical ventilation is often required to support the patient with severe respiratory failure. Increased FiO2 is required to maintain adequate PaO2. PaO2 by FiO2 less than 300 is diagnostic requirement for ARDS. Okay, hospital acquired pneumonia presents with fever, purulent cough. Although it may sometimes progress to ARDS, the pneumonia is usually lower rather than diffuse in onset and does not cause rapidly progressive hypoxemic respiratory failure. Iatrogenic volume overload is a rare, but in the absence of cardiac dysfunction, postpartum cardiomyopathy can occur from the last month of gestation to 5 months after delivery. However, it is unlikely in this patient with no jugular venous distension, S3 or cardiomegaly on chest X-ray. Her mild edema of a lower extremity is likely due to pregnancy. Okay, okay, yes. ARDS, acute ARDS, direct pneumonia and inhalation, or indirect is sepsis, pancreatitis, trauma, lung injury, inflammatory cell activation, and increased permeability, fluid and cytokine leakage into the alveoli. Pathophysiology is decreased lung compliance, alveolar flooding, and increased work of breathing, severe VQ mismatch, intrapulmonary shunt, severe hypoxemia, and increased hypoxic pulmonary vasoconstriction, increased right ventricular afterload, and acute pulmonary hypertension. Diagnosis: new bilateral alveolar opacity within 1 week of insult, edema not explained by heart failure or volume overload, hypoxemia with PaO2 by FiO2 less than 300. Sorry, yes. Right side is JVP, right artery catheterization, left side is pulmonary capillary wedge pressure. Okay, this patient with extensive mucosal candidiasis, white plaque that is suggestive of immunosuppressed AIDS, now has fever, cough, dyspnea, hypoxemia, together are highly susceptible of pneumonia. Immunosuppressed patients are susceptible pneumonia due to typical organism strep pneumonia as well as organism pneumocystis zeroveci. In pneumonia, the alveoli become filled with inflammatory exudate. The alveoli become filled with inflammatory exudate. With inflammatory exudates. Sorry, I lost. Oh, sorry. In pneumonia, the alveoli become filled with inflammatory exudate, leading to hypoxemia due to marked impairment of the alveolar ventilation in the affected portion of the lung, the results of right to left intrapulmonary shunting, an extreme form of ventilation perfusion mismatch, in which there is perfusion of lung tissue in the absence of alveolar ventilation. Depending on how much the lungs are affected by intrapulmonary shunting, the resulting hypoxemia may or may not correct with an increase the fraction of inspired oxygen FiO2. Severe pneumocystis jirovecii pneumonia in particular may cause widespread intrapulmonary shunting with hypoxemia that is difficult to correct with supplemental oxygen.
Fine, if you want to go take,
Okay,
I'll see you tomorrow.
okay.